Clap your hands.
You clap your hands to the rhythm.
I'm so sorry. I have two last names.
Yeah, we're talking about vocal health today.
That goes down. So Mickey is my dad's name. Alex. So if I were to have children, your child, and next to my child, so Mickey and Shake.
You were sick. Usually out by now.
Sorry. No. If it's a girl.
I'm going to be mediocre.
No. I have not talked to her in no way. So I got to her.
Just so funny.
And then like the other day I was okay, so I need you guys to keep it up. Okay. Help me out. I know. I think she just doesn't want to do it. No, I'm gonna be really at the concert. The joint concert. Yes. I can't speak.
Not like I don't want to you're just like.
Okay, guys, no, I don't.
Oh my god. We supposed to like pull off just talking to her. Someone probably gonna also on the floor, okay. No, you can have the chair. There's enough, no, I the person who's gonna do this. Let's both sit on the floor. Otherwise, I'm gonna take the chair.
What do you want me to do? Just like,
Ladies and gentlemen, thank you so much for coming this evening. Really excited to be here myself and hear this presentation. I have been to see Dr. Friedman before. He has looked at my little bitty vocal folds, and I've also been to see the amazing Christine Martin and Steve, who I just met this evening. You know, oftentimes at the beginning of the year, one of the faculty gives a short speech or sometimes a little seminar on vocal health and how to take care of yourself and what to do if you, start to feel sick or other issues with your vocal folds. But now we have the expert in the field here, Dr. Friedman, who's going to give us a presentation about these things, and we'll leave some time at the end to answer questions. I know a few of you may have to leave a few minutes early, so when that time comes, just try to exit quietly to get to your rehearsal. Otherwise, please help me welcome Dr. Friedman.
Thank you so much for allowing us to come here and give a talk. I know our time is limited and it is a beautiful Wednesday afternoon, so we will try to move quickly. We're going to try to limit questions, I think, during our talk, but we'll have some time afterwards for questions. I'm sure there will be some. So we're here to talk about care of the vocal performer's voice. And sort of the first things first, who are we? Well, we're part of the North Shore University Health System Voice Center, and really sort of this is an entity that it really consists of the three of us. I'm a laryngologist, which is to say an otolaryngologist, an ENT doctor with subspecialty training and expertise in disorders of the larynx, and particularly disorders of the voice. So it's one of the few times you train more to have a shorter child. But I'm also accompanied by our team of voice pathologists, who again sort of are speech pathologists that subspecialize in voice disorders. So we work closely all the time, and I'm privileged to have them with us too. Our center is located primarily in Northbrook, which is 10 or so miles north of here, but an hour by traffic if you're driving at 5 p.m. And then our voice pathologists also see patients in Evanston as well too. So, but we communicate regularly and work as a team. We're the only voice center of its kind on the North Shore of the city. So I want to give you a little bit about my perspective as a laryngologist in terms of taking care of vocal performers and singers. And I'm going to start out really sort of talking about sort of some of the things that we sort of look for in taking a history when a patient who's a vocal performer comes into our office. And there are certain key questions that we ask every patient, but as when you come as singers or when other singers come in, we really want to know certain types of things that are really specific to singers. We want to know about your vocal training, your vocal type, what kind of genre of music you're singing, upcoming performance obligations, any history of prior voice problems. And then we try to elicit just more than just I'm hoarse or I'm having voice issues. What are the exact sort of symptoms that you're having with either your speaking or your singing voice? And sort of, these can range from a lot of different types of symptoms that folks have: loss of control, breathy, raspy, strained voices, difficult register transitions, difficulty singing high and light. Sometimes there are only difficulties in your singing voice and your speaking voice is fine. But we try to sort of understand that before we do anything else. Again, another sort of thing that is very common to folks that have difficulties as singers is certain medications or sometimes drugs, recreational drugs and whatnot, can affect vocal function. We try to elicit a little bit of history about these kinds of things. So I'm sure none of you drink alcohol, but if you do, you'll find out that it affects the coordination of your larynx, and it has other effects as well. Things that sort of affect the airflow, the airstream into the vocal folds, like inhalers if you have asthma. Those of you who might smoke, which I'm sure no one in this room does, but the idea being that not only can it affect your voice box, your larynx, but it can also affect your lungs and the ability for you to generate good air pressure to achieve good voicing. Fluid balance is a thing that we don't think about that often, but I see a lot of you here with water bottles, and that's fantastic. We always sort of want singers and vocalists to be well hydrated. Caffeine, of course, is a diuretic. Alcohol, same thing. But some of the things you may not think about that sort of cause you to lose water, if you have a cold and you're taking over-the-counter decongestants, antihistamines that you might get over the counter, even some types of just over-the-counter cough medicines can have some effects on fluid balance. And those things are subtle, but they can make sometimes the difference when folks are having subtle voice issues. Even some forms of antidepressant medications can have side effects of drying out secretions. And then there are, of course, other medications or drugs that affect actual sort of structure of the vocal folds. And systemic steroids, like you might be given if you have severe asthma, can affect vocal function for the good and the bad. Even things like non-steroidal anti-inflammatories, those kinds of things, which are Aleve and Advil, those kinds of things can have subtle effects on vocal function, and then hormone levels as well too. So again, these are some of the things that are perhaps more important to vocalists like yourselves than sort of the average patient that might walk in with a voice problem. One of the other things that we have to do whenever you come in with a voice issue, in addition to taking a good history, is to examine your vocal cords and your voice box. How many of you here have had your vocal cords looked at or examined? So just 3 to 4, yeah. So that's usually what happens too, and that's sometimes a good thing because it may mean that most of you haven't had voice issues, and our goal and one of the primary sort of things is to educate you about when to know to come in if you do have difficulties. But oftentimes it's helpful too for people, even when you're in good vocal health, to just come get an exam so you have a baseline. Because many times folks will come in, and it's sort of just human nature, people come in when they have a problem, when things are going well, why would you go to the doctor? But it's helpful to sometimes understand, because sometimes we'll find subtle things that don't look quite symmetric or whatnot, but don't really mean much. And if you know those things ahead of time on the exam, then if you have a problem, down the line, we can sort of go back and compare those kinds of things. So there's two ways that we can examine your vocal cords when you're awake. And a lot of people will say, why can't you just put me to sleep? I don't like to have my vocal cords looked at. Well, the idea is we want to examine not just structure, but we want to look at function, right? And so two different ways. One way is through the mouth with the scope, and you can see here this picture, this woman is not ready to throw up. It looks sort of ominous there, but I'm holding her tongue there with the gauze and putting a scope that sits on top of her tongue, and it's got a 70-degree lens on it, so it looks down at the vocal folds. And this is the view that we get, okay? And so what you hear here is just a normal exam of vocal folds vibrating. So you'll see in low pitches, the vocal folds come together and vibrate nicely, and then in higher pitches, they stretch out and elongate. As you do a pitch glide, you can see that happening sort of in real time. So this kind of equipment isn't commonly available in otolaryngologists' offices. They don't have what's called stroboscopy. Stroboscopy is sort of one of the key components. If you look here on this slide, she's holding something on her neck. It's a little microphone that's actually an accelerometer. If you sort of take your hands and you put it on your voice box and you say "ee," right, you'll feel that vibration. And so what that microphone does is it picks up the number of times your vocal cords are vibrating, and it changes in real time as you change the pitch. And it flashes the light, so you hear this kind of noisy background noise. That's the strobe light that lets us look at the vocal cords vibrating in what looks like apparent slow motion. Because in general, when you make sound, even if you're talking, your vocal cords are colliding about 100 to 200 times per second. So if you look at it with just regular continuous light, it looks like a blur. And sometimes we can detect subtle things about voice problems based on the pliability and the softness and the vibration patterns of the vocal folds. So when you're examining the vocal folds through the mouth, oftentimes you can't do very much other than say "ee" with your tongue hanging out of your mouth, and it doesn't really sound like much of anything. We also sometimes will examine patients through the nose with a flexible scope, and that's what this picture is showing here. What you're going to see is that we can get both a more panoramic view and a sort of closer view of the vocal folds. And the idea being that you can do more complex vocal tasks other than just say "ee" in high and low pitches and do pitch glidings. And so sort of what you'll see here is, again, a normal exam for a patient who came in. You'll see the same sort of concept. Vocal folds are at low pitches and high pitches. They become more tense. But now we can actually look at her. So that's often helpful when you're doing a detailed exam to say, I'm having difficulty with this note or this transition, and we can try to mimic and sort of have you do those kind of vocal tasks and sometimes pick up on subtle things that you wouldn't ordinarily detect. So these two types of exams are complementary, and one is not better than the other. They have different values for different types of problems. There are several things that we see very commonly in patients that come in with voice issues, and particularly in vocal performers. And one of them is an entity known as muscle tension dysphonia. And this is sort of exactly what it sounds like. Dysphonia means hoarseness, and muscle tension is what it sounds like. And sort of there are varying degrees of this, and we detect this oftentimes based on a history, but also on the examination. In general, when you go to make sound, the vocal folds should come together, but there should be a sort of nice kind of oval shape around them. But when we see examinations that look like this, where there's that compression of those tissues, or even like that, where you can barely see the vocal cords, and this person's not gagging, this is actually sort of during an actual exam, we know that there are some issues of tension in the muscles around the vocal folds. That can happen for a lot of different reasons. Sometimes it sort of happens as a result as a compensatory mechanism for something else. But oftentimes it's not necessarily identifiable from a specific cause. But it's one of the entities that our voice pathologists, Chris and Steve, are fantastic at treating, and a very common thing that we see. Here's another thing that often gets blamed for a lot of voice problems, and sometimes is contributory, but sort of, again, is something that is we see commonly, particularly in vocal performers, and that's acid reflux or stomach contents that come up into the esophagus and all the way up into the throat. The technical term for this is called LPR, laryngopharyngeal reflux. And there's different varieties of this, acid-based, non-acid-based, but when we see patients that have swelling and irritation in the sort of back part of the voice box, which is this sort of back of the voice box, but the front part of the bottom of the throat, that can sometimes indicate this disease. And there are various ways to treat this with medications and diet, and very rarely a surgery is required. So some of the sort of things that we end up treating for folks that come in, particularly in sort of an acute fashion, which a lot of vocalists do come in for. There are some common things that are sort of relatively easy to prescribe that sometimes can help folks with voice issues when there's nothing more serious going on. So things like Mucinex you've seen on TV, those little green guys on the commercial and whatnot. I was going to put a picture of one on here, but I forgot to do that. But the point being that I do not own stock in Mucinex. But, the point being that that's oftentimes a good drug to take to thin secretion, to be a very thick secretion. There are different types of Mucinex, just this plain old standard stuff without the decongested portion is usually a good thing to try and has low risk if you're having difficulty with thickened secretions or sort of clearing your throat a lot. Again, we talked a little bit about reflux. I won't dwell on it here, but the idea being that sort of there are various degrees of antacid medications, from the on-demand stuff like Tums and Gaviscon all the way up to the stronger medications like omeprazole, prednisone, and so on and so forth. A lot of folks can have voice issues not specifically related to diseases only in the larynx, but also allergies to the environment or allergies to seasonal issues. And so nasal sprays sometimes are helpful and often managing the initial symptoms of that, and sometimes systemic medications. And one of the nice things about where we are is that sort of we work with about 1,000 different physicians of different subspecialties. So we believe this is a significant cause of your voice issues. We'll refer you to an allergist who can sort of take this and investigate it in a more sophisticated fashion. And then antibiotics are sort of, a lot of people come in sometimes with acute voice issues and say, I want to have, I need antibiotics. And the reality is that sort of laryngitis or sort of is often caused not by bacteria, but by viruses. And so antibiotics really don't have a substantial place in my practice unless we have symptoms and signs on the exam that show a true bacterial infection. Many times when patients have a viral laryngitis, and as singers, you guys are getting these just like the rest of the population is, but you're more sensitive to the effects of it, and sometimes the effects of the laryngitis can linger for several weeks afterwards, long after sort of the speaking voice has gotten better. And so many times sort of, we will try to stave off giving antibiotics, but again, sort of help you through those situations when the voice is disordered as a result. But there are times when patients genuinely do have a bacterial infection of the respiratory tract, or specifically of the larynx, and then antibiotics are absolutely indicated. One of the things that we talked about before, and we mentioned here as well too, and bears repeating, and I'm sure voice pathologists will talk about, is just hydration. Actually drinking a lot, right? Staying hydrated, particularly if you're sort of consuming diuretic type beverages, replacing that lost water. So the old adage of 8-ounce glasses of water per day is probably sort of not true, but the idea being that you should be drinking enough so that when you pee, your urine is nice and clear, not that sort of dark yellow kind of thing. So, and another key thing about hydration too is that in general, it's better to, if you take any volume of liquid that you're using to hydrate yourself, and you sip that over the course of an hour, take a sip every 5 to 10 minutes or something like that, it actually stays and translates into more secretions, translates into thinner secretions than if you were to take that whole volume and just drink it right away. Because what happens then is your blood volume goes up, your kidneys say, whoa, too much, and you urinate it out. And so that same volume consumed over a longer period of time is actually more efficacious as it relates to keeping your secretions hydrated. So, steroids. What about steroids as it relates to singers that come in with acute vocal difficulties? Well, they certainly have their benefit. They reduce tissue swelling, and they work very well to do that, particularly for vocal folds that are swollen. If you have a performance coming up, and sort of, all of a sudden you get a cold and your voice is shot, sometimes there are good indications to prescribe a short course of steroids. They're generally not a good thing to take long term, and if you're in a pattern of needing them consistently, sometimes there's something else that's going on that we need to take a look at. But they do have their side effects. One of the main sort of risks of these is a hemorrhage in the vocal fold, and I'll show you that in a subsequent slide. But the idea being that that's a sort of one of the few laryngeal emergencies as it relates to singers, and if you have a hemorrhage, you have to stop singing and be on voice rest, usually for a week, sometimes longer. So you always want to be sort of thinking about risks and benefits. They can cause you to retain water, have mood changes, irritate your stomach, and increase reflux as well. So patients often will say, well, when I have vocal problems, when should I rest my voice? And in general, there are kind of two categories where I think that this is a good thing. There's sort of what I call the possibly category, and certainly in the case of an acute laryngitis, that's oftentimes a good time to rest your voice. Like, again, depending upon the degree of it and whatnot, there may be indications to do it absolutely, and there may be indications to pursue, continue with your singing, but to do it in a cautious fashion. If you have a performance and you feel like, in general, sort of your vocal capabilities would not be sort of, you can't live up to your vocal reputation, that's a time to consider sort of resting your voice. Same thing with respect to sort of a performance obligation. Again, these are sort of very individualized, personalized decisions that I often have with singers as it relates to sort of, these types of acute vocal issues. Are there absolute times you should rest your voice? Yes. When you have a vocal fold that looks like this, so here you can see obviously bright red vocal fold on the left side, it's full of blood. That's a vocal fold hemorrhage. There's no other solution other than to rest your voice. And sometimes singers will know the instant that something like this happens. They can be singing and literally things can change in an instant when that happens. Fortunately, it's very rare. And oftentimes people come in very worried about a vocal fold hemorrhage. And in general, if you're questioning whether you have it, it's not a bad idea to get it looked at. But generally, if you have it, there's no question that you do in terms of sort of your vocal capabilities will absolutely suffer in a significant way. I'll show you another example of that later. Sometimes patients will develop problems with ulceration in the vocal cords. Oftentimes this happens in the context of a really bad cold where you've been coughing for weeks, sometimes sort of to the point of sort of, a cold that's been going on for weeks or months, and the edges of the vocal cords will become traumatized from colliding with one another. This is another one of those situations where sometimes you have to go on voice rest. Fortunately, it's pretty rare, particularly in sort of young singers. I don't think I've seen this very often in that population. We tend to see it in older folks who are sort of have other medical problems in addition, so not as common in singers. But if you do have this, sometimes voice rest is the only way to help this. And then after vocal fold surgery, depending on the type of surgery and the reasons that it's done for, voice rest can be a crucial part of that recovery. So I'm going to transition now to talk a little bit about some lesions of the vocal folds. These are sort of the three most common lesions: vocal fold nodules, polyps, and cysts. The sort of holy trinity of structural problems in the vocal folds that we see. Or if you're a Wizard of Oz fan, the lion's tigers vocal issues. So the concept being that sort of these are different types of what we call phonotraumatic lesions. And these tend to happen in folks that use their voice a lot. So singers, for instance, performers of any kind, but also teachers tend to develop a lot of these types of problems. Anyone who uses their voice a lot, whether it's for an occupation, or sometimes folks that are just very naturally sort of effusive and very sort of extroverted personalities, we tend to see that more commonly. So nodules are the lesions up here. They tend to occur in pairs. They usually happen on the edges of the vocal folds, right in the center, and they're basically calluses that exist on the sides of the vocal folds. Many singers will have some form of nodules. The good news is that it doesn't necessarily mean it's the end of your career. It doesn't necessarily mean that you have to have surgery. And the idea being that we work with singers that have those difficulties to try to help manage what sometimes can be a chronic but manageable condition. Something like this is a little bit different. This is a vocal cord polyp. And sometimes people use the words synonymously, but they're actually very different. You can see a polyp oftentimes is just on one vocal cord. And this polyp's been there for a long time. How do we know that? Because you can see, if you see a little divot here, this has been colliding into that. And in general, when you speak, we talk about the vocal cords colliding with one another maybe 100, 200 times per second. Well, if you add that up over the course of a day, it's about 1.5 million collisions if you're a woman, or about 750,000 if you're a man, just because the pitch of the voice is lower, so the vocal folds vibrate. Not to say that. It has nothing to do with that. So, but the point being that that's like it's like a hammer hitting a board, right? So sometimes that can create permanent trauma on the other vocal cord. Okay? And then here's a vocal fold cyst, which is actually a fluid-filled lesion that's underneath the surface of the vocal fold. So the idea being that some of these lesions do require surgery. And I wanted to tell you a little bit more about that. my specific training in laryngology was really with a gentleman who's sort of really known internationally as a sort of somebody who treats high-level singers and vocal performers who have required surgery. So these are a few of the folks that he has managed and who have been very public about their need for vocal surgery. You'll see, obviously, sort of Adele, who's here. She publicly thanked the guy who trained me at the Grammys when she won it because he was the one who did her surgery to treat her vocal fold polyp. So the idea being that surgery can be done. It can be done in high-level vocal performers, and it can be very successful. Folks are oftentimes very hesitant about laryngeal surgery, and it's not that this is always the first option. In fact, many times it's a last resort when patients come in, particularly with these phonotraumatic type lesions. But the point is that when it's done well and it's done in a sort of sophisticated way with good equipment, the outcomes in general are quite good. And I want to show you a little bit about how we do surgery. So there's nothing here that's too gross, but again, we're going to show some videos here. There's nothing bloody, but the idea being that sort of, this is how we do surgery on vocal cords. This is a metal tube that's called a laryngoscope. And basically, surgery is done under general anesthesia. You're completely asleep, your vocal cords are paralyzed, so they're not moving. We put the scope through the mouth, and it's got a little light that's there. And sort of this is the view when you look through the mouth. You're looking through a straight line from the mouth all the way down to the vocal folds. Now remember I talked about the fact that sort of surgery on vocal cords is best done when things are as precise as they can be. So one of the ways that we make things precise is to use a microscope to give us magnification. So this is an example of the amount of magnification that we get. This is a performer who's in the CSO who had a small hemorrhagic polyp on the right vocal fold right here, and a little reactive lesion here. And what you're going to see is a little probe that we're using just to sort of size this lesion. Now you're going to see this probe here, and I'll show you what the same probe looks like next to a penny. Okay? So you see the amount of magnification that we get, and it's that kind of magnification that helps us be precise so that when patients, or particularly patients who are vocal performers need surgery, it can be done in the safest, most effective manner. So I'm going to show you a little bit more about how we do this kind of surgery. So again, here's that little polyp on the right side, and you see again, it's only about 2 millimeters, but it was enough to create vocal difficulties that are substantial for somebody who's a professional vocal performer. And what we do initially is to make a small incision right into the vocal cord next to that little polyp. And we raise up a little flap of tissue. That flap of tissue contains the polyp. Here it's easy to see because it's red. It's red because it's filled with sort of old blood. That's why we call this a hemorrhagic polyp. And the idea and the key thing about surgery, whenever you do it on the vocal cords, is to save the vibratory tissue that is often deep to the lesion that you're trying to treat. If you don't do that key move, that's when you get into trouble in terms of having stiffness in the vocal folds. And so what we do is take this flap of tissue, separate it first from that vibratory tissue. That vibratory tissue has a special name. It's called the superficial lamina propria, or SLP. And it is what gives vocal folds the capacity to be elastic and supple. And so that is a tissue that if it's damaged or it's removed, it does not grow back. It grows back with scar. You get pliability issues and ultimately sort of permanent courses. So we want to be very careful about how we do this. One of the sort of unique things that we have in our tool belt is a specific type of laser. And this laser is called the KTP laser. What you're going to see here is this laser being used in a pulsed fashion. Each time you see that little flash of light, the laser is being used to treat the blood vessels that are part of that hemorrhagic polyp. And so the idea is that this laser is not only precise, but it's precise enough to be attracted to things that have blood vessels, and things that don't have blood vessels, it's not as attracted to. So the idea is that lasers create heat. Heat, again, we want to sort of make sure we minimize any kind of trauma to the vibratory tissue that vocal cord. So this laser is delicate enough that it won't poke a hole in that flap, but still can treat that little hemorrhagic component. And then what we do is use some very small instruments to remove that tissue from the vocal cord. If we had done this before without using that laser, this would be bleeding and the precision would go down. And remember, these instruments are about 1 foot long. They're going through that little metal tube that you saw, and this is highly magnified. So the point is that the surgery has to be done by somebody who's done a lot of it and is well trained if you're going to sort of have this kind of surgery on your vocal folds. But the point being that after this is done, what you end up with is a flap of tissue that's been cleared of that polyp, and we preserved that lining of the vocal fold that's there. Okay? And then what we do basically is oftentimes the flap will be a little bit too large because of the lesion. We trim it and lay it back down. So you take something that looks like this and you make it like that. So here's another example of a vocal performer. She was a PhD student at Northwestern in voice, coloratura soprano, who actually had repeated hemorrhages in this vocal fold on the right side. This is what her exam looked like before.
And gently clear. Going high pitchy.
So what you'll see is that hesitation in terms of vocal capacity and difficulty sustaining high and light notes. And for a coloratura soprano, that's where all of the, that's the key sort of things that she needs. So she underwent the surgery. We operated on her. This is her about 2 months after her surgery. So you see she's got nice pliability in this right vocal fold where the lesion was, and everything has been preserved on the left as well too. So by reestablishing that, by doing surgery but doing it in a safe manner, we were able to correct her vocal difficulties. So vocal fold polyps come in lots of different flavors. Some are sort of pedunculated like this, some have broad attachments like this. The point is that we can use the same principles of surgery to treat them and take all these lesions and do it in a safe manner. Same thing as it goes for vocal fold cysts. I'm going to sort of speed up here because I know we're running a little short on time. Same concept. We remove the cyst but save all the vibratory tissue and lay that flat back down. And then last thing about nodules, I want to show you just a little bit more about this again. Because the concept is that this is probably the hardest of those 3 lesions to treat surgically because, number one, it's oftentimes the result of chronic trauma on the vocal folds, not just a one-time incident. Somebody, for instance, might be yelling or giving a performance and things change, like that singer you saw who had a hemorrhage in her vocal fold. She knew the instant that it happened. And even though she rested her voice, it developed into a little polyp. Nodules many times are more of a chronic disease. They're insidious in sort of their onset. When I see patients and we diagnose them with nodules, many times they'll say, yeah, I've been having difficulties for the last couple of weeks, but you know what, as I think back, this has been a process that's sometimes been months or even years. And so surgery is absolutely not the first go-to for vocal fold nodules, and I want to make that point clear here. But for patients that continue to fail to meet their vocal demands and having undergone and worked with voice pathologists like Chris and Steve, surgery can sometimes play a role in helping manage vocal fold nodules. And so the idea is, again, sort of when you see vocal fold nodules in the operating room, the inclination is just to pull it out and snip and cut. And that's sort of, this is a picture that actually was taken off the internet where that's exactly what is being described here. So this is a nodule on this vocal fold, and what you see here are these little red dots. That's actually the sort of pattern of a laser. And sort of what happens is that they have these really cool lasers where you can aim the pattern anywhere you want. You hit a button and within less than half a second, the cut's made. And so the idea being that that's okay for some applications, but it's really not the best and most precise way to treat nodules on the vocal folds. And the reason for that is here. This is a schematic of the vocal cord that looks at what we call the layered microstructure, the anatomy of the vocal fold. It's a cross-section of the vocal fold. The black line here represents just the surface lining. It's called the epithelium. The yellow here is that vibratory layer called that superficial lamina propria. And nodules tend to occur right at the interface, this area in green between those. It's scar and fibrous tissue that builds up there. And so if you tap into